Hello, and how are you? Welcome to another session on FGM long-term complications and their management. So this will be the final bit when it comes to the long-term complications, and we began with the first part, which was on short-term or the immediate complications. And to those who are new here, my name is Winnie Barawa. This is a YouTube channel that focuses on lessons, lectures, and interviews pertaining to healthcare. Now, this is a series that is supported by the Girl Generation in collaboration with the University of Nairobi and ACAF, which is Africa Coordinating Center for the Abandonment of FGM. This is a movement that is dedicated to ending the practice of FGM in our society, and this is part of the method of sensitizing and creating awareness in our community pertaining to FGM and its complications, and also creating awareness on the legal channels that one can take in case you find yourself in such instances. So let's keep up and finalize on the long-term complications. So the list was long, and we began by looking at the neuromas. We looked at the valvular pains, we checked on septicemias and infections, we explained a little bit on urinary retention and painful urinations. So in this bit, we're going to look at cases of abscess, clitoral neuromas, a bit on fistulas, and also chronic urinary tract obstruction. So let's begin with the first part. So fistula and incontinences most of the time tends to occur concurrently because fistula looks at connection between two areas of the pelvic organs or two organs in the pelvic area, and fistulas mostly results into incontinence. So we are told we have vesicovaginal fistulas and rectovaginal fistulas are normally the commonest when it comes to female genital mutilation, and majority of the time they lead into incontinence. Now, vesicovaginal fistula, this is a fistula where there's a linkage between the urinary system and the vaginal openings. And then in rectovaginal fistula, we are looking at connection between the rectum and the vagina. And in this case, both of them can lead into incontinence or inability to control the materials or substances that come out from these two particular systems. So it can occur as a result of injury to the external urethral openings, or it can also occur due to other conditions like obstructive labor. But most of the time, majority of the FGM that are severe, they tend to lead to such complications, that is fistulas and incontinence. In the management bit, we are explaining that if a client has an infection, then you can initiate on treatment or antibiotics treatment or antimicrobial treatments, and then you can now try to identify the cause of the incontinence and the type of FGM that the patient had gone through. So however, if you rule out and find that there's a case of stress incontinence, then you can maybe cancel out the clients and start out on programs such as exercises to strengthen their pelvic floors, and also referral to urologists who can assist with issues around the urinary systems and other complications therefore. Clients who have established diagnosis of VVFs and RVFs, we can still refer them for surgical repairs. They're specialists who have specialized into helping and management of fistulas through surgeries. So the specialist will be able to tell the severity of the fistula and its level by, of course, doing the dye test, which will give us the extent and how severe the case is from the client. So with that in mind, then the fistulas and the incontinence, majority of the time you want to rule out infection first and then establish the types and the levels of the incontinences, and then you can initiate whether treatment through urologist, or you can go for surgical repairs to cover up the fistulas for this particular client. Then when it comes to the cases of clitoral neuroma, we are being told that a neuroma is a benign tumor that arises after a section or an injury has been done on a nerve. So now in the clitoris is an area that is supplied with nerves, almost 8,000 nerves. Now, when during the procedure the clitoris is damaged, it can actually stimulate the growth of benign tumor that can lead to what you're calling clitoral neuromas. So the dorsal clitoral nerve is injured during cutting of the external portion of the clitoris, what we are now quote unquote clitoral glands. So when the nerve fibers regenerate, they do so in disorganized manner, leading to appearance of what we call clitoral neuromas. So this bump here that we are seeing, this is the location where the clitoris is supposed to be located, but however, due to the damage that was done to it, then you can have abnormal growth that can happen around the clitoris, what you're calling now the clitoral neuromas. And they're very painful. Most of the time, they're very painful, and the client will also report signs of extreme sensitivity. So you have to be very careful as you are managing this gland. So we are told that a clitoral neuroma can be asymptomatic, or it might cause what we call allodynia, that is pain from a stimulus. There's also cases of sensations and also chronic pain. So apart from just having a growth, it can also come along with further symptoms and complications that are very unpleasant. Then we have sitting, sexual intercourse, or any friction between the underpants, it can cause pain. So if you realize that, then you can manage these neuromas normally symptomatically. So the beginning of management is usually symptomatically. However, in other cases, you may be dealing with pain management, looking at the discomfort, working on initiating what do we call this, like counseling, because this is a client who has image disturbance or has image that has been distorted, and they may not have the confidence they used to have before the procedure was done. Management of asymptomatic clitoral neuroma, mostly it's dealing with the typical symptoms, and in this case we are talking about the chronic pain, the allodynias. That is now a patient who has extreme pain sensitivity to sensations of touch, things that should not be painful basically. And then there's the sensation of electric discharge in the genital area. So perform or be good at genital examination basically, and you need to be very careful so that you can inspect the vulvas carefully so you can be able to identify the neuromas, as you're being told that some of these neuromas are not always easily visible. So check for the presence of neuromas by touching the area around the clitoral scar with a delicate object. So delicate object could be a cotton swab or a band, so that these are things that are not supposed to cause pain. Now, if you stimulate a sensation there using a cotton swab and the client complains of pain, this will be confirmation of the allodynias, and this is an indication for a neuroma case, because when you stimulate such areas with such objects, it should not produce painful sensations. So advise the woman, however, to wear loose underpants to avoid any form of friction, and then be a bit gentle while examining the patient, as you know that any stimulation around the clitoral areas can stimulate extreme sensitivity, and part of it can come with pain and it can come with discomfort. Then we have valvular adhesions. So with adhesions, we are explained that this is cases where the tissues tend to cling into each other and they close. So we are told that with valvular adhesions, they appear due to inflammations or infections that may have occurred at the time that FGM was performed. So they normally appear as thin, filmy tissue that partially covers the vaginal opening. So as you can see, like the vaginal lips ended up touching onto one another, and then it closed, or it ended up completely blocking the vaginal opening. So like in this case here, where we are being told this is a case of complete adhesions of the labia, giving the appearance of an absent external genitalia. Very common among the type 3 FGMs, where the lips are usually sutured, and due to improper healing, you find that these lips can end up basically attaching to each other and closing up the external genitalia, so that it appears like there's an absent or absent closed genitalia. So these are cases of valvular adhesions. It can be complete cases or incomplete cases. So in the management of vulva or valvular adhesions is that if the adhesions are thin, then you can go for local anesthesia and perform a blunt separation by gently pulling the labia laterally with the fingers or cotton-tipped swabs. However, with thick adhesions, you may require surgical separation again under local anesthesia. However, you need to be keen and provide guidance on vulvar hygiene. So give the woman a follow-up appointment in order to monitor the progress. So this requires also follow-up. It's not just a home care management, but even as they do that at home, you're putting them on antibiotics or antimicrobials, and you want to clear any sort of prophylactic infections. You want to make sure that the lips have properly separated from each other and you're not worried of them adhering again. You want to also maintain that the valvular area is clean and does not worry about getting infected. And finally, we have the case of vulvar abscess. So a vulvar abscess is a localized collection of pus that usually appears as a tender and reddened mass in the genital areas. It's quite painful and warm to touch. So in the vulvar abscess, this is simply we are referring to pus forming. Mostly this comes from infections, because when the infections clog this area, they bring state of inflammation and secretions or excess production of secretions, which can end up clogging this area and making it very uncomfortable. So the management of vulvar or abscess is to do pain management by administering pain medications. And then you can also talk about spontaneous drainage of the abscess. And you can also talk about soaking the affected area in warm water, or to talk about the sick bath. This is to clear any microbials, to clear any collection of pus there. You want to kill as much microorganisms as possible and to keep this patient free from further infection. However, warm compresses against the affected area can also be recommended, but the key focus should be how do we clear this pus as possible and how do we clear the infections around this particular area. Thank you again for keeping up all the way to the end. Don't forget to subscribe, share in your platform, give some comments, and like our video. And if you still want to join our channel, please click on the join button and be able to join our community. You can also support our channel via super thanks. So you can offer different super thanks and you'll be able to select the one you wish. That will go a long way into supporting our channel and enabling us to make more videos to share with you. So thank you so much, and see you in our next classes. Bye bye.